Ladies and gentlemen, please take your seats. The program is about to begin. Ladies and gentlemen, please take your seats. The program is about to begin. Ladies and gentlemen, please mute your cell phones. Ladies and gentlemen, please take your seats. The program is about to begin. Ladies and gentlemen, please mute your cell phones. Ladies and gentlemen, please welcome Dr. Robert Kaplan, Associate Director of the Office of Behavioral and Social Sciences Research at the National Institutes of Health.
Thank you and good afternoon. It's a pleasure for me today to introduce Dr. Francis Collins. Dr. Collins is both a physician and a scientist, holding both a PhD and an MD degree, who is the director of the National Institutes of Health. And I think all of you are aware that the National Institutes of Health is the largest supporter of biomedical research in the world. Dr. Collins has had a very distinguished career, coming to the NIH from the University of Michigan, where he initially led the National Human Genome Research Institute, and in that role led an international effort to sequence the entire human genome. Quite a stunning achievement. He's been elected to the Institute of Medicine and to the National Academy of Sciences. He's a recipient of the Presidential Medal of Freedom and also the National Science Award. Now, I think many of you are aware that the NIH is a very complicated federation of 27 institutes and centers. And each of these centers has remarkably broad research programs and has its own director. Dr. Collins serves in the remarkable role of coordinating all these efforts. And I'd like to say that when you look at all the things that are done at the NIH, if you can imagine every single sub-discipline of medicine, every specialty and subspecialty, and then add to that the many subspecialties of science, ranging from cell biology all the way through sociology, there are people with literally hundreds of different training backgrounds that are participants in this process. The NIH receives about 80,000 grant applications each year, and through a highly competitive process awards them to deserving recipients. So I've always found that it's quite remarkable that Dr. Collins is able to take the telephoto lens and see the big picture, but also use that macro lens and to dig down in all these hundreds of disciplines and seem to understand the important themes. So it's a great pleasure for me today to welcome Dr. Francis Collins, a great scholar, physician, and also a great guy. So please welcome Dr. Collins. Thanks.
Thank you, Bob. Good afternoon to everyone. Delighted to see some of you are still here. I know this has been a meeting of several days in length, with a lot of great information being spread around, conversations in the hallways, at the exhibits, and in big rooms like this one. And yet you still seem to be here with smiles on your faces, and I hope to maintain that same sense of momentum that's been going on throughout the course of the last couple of days. I just am fresh back from London from a meeting of the heads of international research organizations, which is why I could not have the chance to meet with you until today, but I've been getting regular briefings about this meeting from Dr. Kaplan and others, and it certainly sounds as if this meeting just gets more and more exciting every year. We're clearly in a zone here where technology is meeting health in exciting ways, and the future is very bright indeed. But I want to focus particularly here in my presentation for the next few minutes, as the title says here, way cool app, but does it work? And particularly on the need to be able to assess new technologies that are advancing health through the use of mobile approaches to make sure that we are rigorously assessing whether they're actually changing outcomes, because that ultimately has to be the way in which this field will be judged. There are so many cool apps that this is a great opportunity, but also a great challenge. So I want to walk through some of those things here with you. Of course, this audience doesn't need a reminder about what a powerful opportunity is presented by the accessibility to cell phones across the world in places where oftentimes health has been more difficult to pursue with technology. Cell phones offer that. And of course, mHealth is not just about cell phones, but it's a big part of it. And I'm delighted that this meeting has had a particular focus on global health applications, because that certainly seems like one of the major opportunities, and I'll mention one or two myself. In terms of the way in which this has been trending upward, this Pew study, which I wouldn't be surprised if other folks have referred to, pointing out that mobile health in 2012 is not only happening, but something like 1/5 of smartphone owners have health apps. So this is getting into the mainstream rather quickly. I've had my own enthusiastic view of this for a while. I wrote this article in Scientific American a few months ago to talk about how this promise of mHealth is playing out. And certainly from my own experience, both as somebody who's a general admirer of the Fitbit, although I lost my Fitbit on the train to New York last week. If you find one that says, "Francis, would you please send it back to me?" because I'm missing it. I also had the chance to take part in a clinical trial of a particular application on the iPhone, which many of you may recognize because this is the AliveCor heart monitor. And yes, I was one of the consented participants in the clinical trial. And this has, as you know, just in the last couple of days, resulted in granting by the FDA of a Class 2 501k clearance for this application for transmitting EKG potential arrhythmias to healthcare providers. A very interesting and exciting opportunity. NIH, as you heard from Bob Kaplan, is a major player in terms of supporting research on mobile phone technology. This shows you the number of awards that we have given over the course of the last 7 years. You can see in 2009, 2010, there was a particular bump up. That was the Recovery Act. And some people thought, well, you know, that was just because we had some extra funds to spend during those 2 years. But look to see what's happened since then. 2012, up to the highest level ever, about 200 awards. And by the way, most of those are to small businesses as part of the Small Business Innovation Grant Award Program. If you are a small business and you're interested in those, you can go to the NIH homepage and learn a lot more about it, because that program is actually in the process of being expanded, even in difficult budgetary times. And we're very excited about some of the things that are coming out of those grants that you see. We've been funding in increasing numbers. We also are very interested in providing training in how to conduct rigorous research with these new technologies. And of course, many of you are aware, because you may have participated in some of these training programs a year ago at this summit, and again this summer in a special summer session, and then at this meeting in a session that was sold out almost immediately on Saturday and Sunday. Some of the examples I could mention in terms of the kinds of NIH support for mHealth that are, I think, particularly interesting to this audience, some of which have probably been talked about at this meeting in either large or small sessions. I'll just give you a few examples. In each case, I'm mentioning the name of the investigator. If you're interested, you can basically copy that down and have a look. Basically, this covers a lot of ground. Some of these are to encourage healthfulness, focusing particularly on prevention and wellness. On the left there, you see a smart move, which is something that attaches to footwear and that allows individuals to track their activity, giving them feedback about how that feeds into calorie burning. On the right is a gadget which is actually on the person's shirt pocket, but you see in the animation there what's in it. So this is a unified sensor system that uses a video camera, a microphone, a GPS, and an accelerometer. So this is able to transmit dietary and physical activity in real time. And developing software to view and process this is very much in the works, as a means, again, of monitoring lots of individual activities in the name of health. Some other things to monitor health and environment. The implantable biosensor for diabetes testing that you see there in the upper left involves the implanting of a very small glucose monitor under the skin, which is then capable of, in real time and continuously, transmitting glucose levels to the watch that's worn on the wrist, and that in turn can transmit it to a healthcare provider in order to have a much better sense of what's happening in a diabetic than one can achieve by occasional finger sticks. Obviously, a very exciting approach. On the bottom of the screen is an approach to try to develop what might be a real advance in monitoring hypertension. As most of you know, hypertension is extremely common in developed countries and increasingly in developing countries as well. And the difficulty we have in monitoring that is really considerable. It's very clear that doing monitoring when somebody walks into the doctor's office is not sufficient for really finding out what's going on during the course of the day. And ideally, one would like to have continuous, non-invasive monitoring of blood pressure. And that's been difficult to achieve since, of course, it generally has required a cuff. My daughter is actually a physician in North Carolina whose main practice is hypertension. And the opportunity to be able to do continuous home-based monitoring of her patients who all have very difficult to manage blood pressures would be an enormous advance. And obviously much progress being made here, and we have supported some of those enterprises. You see an example here. In the upper right is a system which allows you to actually measure environmental exposures in places where you might want to know, particularly hydrocarbon and acid vapors. This particular system capable of being sensitive down to the parts per billion range in real time, and can be spatially resolved because it's connected to a GPS. Another example of how we are supporting, in this case, environmental sampling. And other things to enhance your senses, particularly for individuals who have impairments of body senses. The PhysioLink earpiece, here designed, and I'm sorry to say earpiece seems to be misspelled, but you know what I mean, designed to assist individuals who have hearing problems, who have particular difficulties in a noisy room making out conversation. This is pretty classic, even for individuals who have a hearing aid, that in a noisy room it may be hard to make out the conversation. So this is designed to be able to assist that by augmenting those hearing aids with wireless replay capabilities and a smartphone interface so that users control more of what they hear. On the right, the Percept project, which enhances navigation for people who are visually impaired by using sensors in a specially designed glove to enable the navigation of new settings that those individuals are not familiar with. And then, of course, there are other applications that involve laboratory measures. On the left, you see a pretty ambitious gadget which allows the measurement of various cellular properties, in this case using a chip-based micro NMR unit, which is smartphone powered and can measure things such as proteins, biomarkers, DNA, bacteria, virus, drugs, calcium, and so on. This is very much a way that one can bring this kind of laboratory analysis to almost any location and get very rapid results. On the right is an effort to try to make it possible in a distributable way to look at potential oral lesions using a fiber optic microendoscope, which allows the visualization on a cell-by-cell basis of lesions that might be of concern. Another example of that same idea, which is low cost and portable in terms of use in oral cancer screening, is shown here. And on the right, the Lucas lens-free microscope, which makes it possible to be able to do such things as CD4 counts in a circumstance where one doesn't have access to expensive microscopes. Using this particular instrument, which counts cells by their diffusion properties under light, is actually shown to be quite valuable and reliable, and transmits the results through the cell phone network to a laboratory so that one can get such things done quite remotely. And you can imagine how valuable this is in managing, for instance, such a condition as HIV. So those are all exciting opportunities. And we are as jazzed about them as almost any you can imagine, because of the way in which this opens new possibilities of prevention and treatment of disease. But we also are very concerned that as this technology comes forward so quickly, we need to be sure that we're collecting the right evidence to show that these mHealth applications actually improve outcomes. And that's what I'd like to turn to now, because I think that's a very important message for the mHealth Summit going forward. Clinical trials on mHealth ought to be the best way to determine what is actually working and what isn't. But here at the end of 2012, surprisingly few mHealth interventions have been tested systematically in a standard approach that most scientists would accept as really demonstrating unequivocally and objectively that the technology is working. The gold standard for that kind of evidence is generated by a randomized controlled trial. And to do anything short of that, if you had the opportunity to do a randomized controlled trial, is likely to expose the results to questions about whether they are in some way biased. Obviously, in some instances, that's not practical, and non-randomized observational studies can certainly be generating hypotheses, and a lot of science gets done that way, but those will always be subject to concerns about confounding biases, about who utilized the technology and who didn't. there's really no substitute for having a randomized trial where you have potential participants and you choose by a completely random fashion who utilizes the technology, who doesn't, and then you follow the results going forward. And then you can be quite confident that the difference in outcome, assuming your groups were well matched and there are ways to assess that the difference then must be due to the technology and not to some other factor that biased the study. And I certainly would like to urge this audience, as you are moving forward with these amazing new developments, to think of ways to test them, not in observational trials if you can avoid it, but actually to randomize the study and see what the results is. Because the plural of anecdotes, as is often said, is not data. And we can all tell wonderful anecdotes about particular technologies and what they have done in individual circumstances. I tell those myself sometimes, but if you really want rigorous proof of efficacy, that won't do it. Instead, this field is going to, I think, need to embrace the idea of scientific rigor even more enthusiastically as we go forward. And there are some who have done so, and the results in some instances have been quite gratifying. I'll tell you about a particular study called WellTel, which was designed to try to figure out whether interactive text messaging to promote HIV patient retention in medical care was effective. Obviously, this is an enormously important effort to try to be sure, as we are increasingly able to make antiretroviral therapies available to individuals across the world. Is it working? Is there, in fact, compliance? Are there problems in terms of getting the drugs to people in a way that they can keep to a schedule? Are there complications that we're not able to assess? And you can imagine how challenging that is when those patients may be scattered all over the world, and many of them in low-resource settings with relatively limited medical expertise nearby. So here, of course, is a golden opportunity to be able to utilize mobile health approaches to remain in contact with individuals who are on antiretroviral therapy and identify problems and act quickly if they occur. So this is a simple SMS approach where basically each individual who is in the program to receive antiretrovirals gets a weekly text message from an AIDS clinic in Nairobi, simply asking, how are you? And they are to respond with either fine or problem. And if the answer is problem, the nurse then contacts the individual to find out what the problem is and tries to make a solution happen. And so this was exposed to a trial and happily did, in fact, in this case, show significant improvement in antiretroviral adherence and viral load suppression, a pretty strong outcome there, with the availability of this contact information in order to identify problems and act on them quickly. This is now being tested in Kenya to see whether the same kind of approach can improve patient retention at the beginning of treatment, at the timely initiation of medications and outcomes, extending it even further. And here's a very nice example and a very concrete one. You may think this is rather simple, and it is, but the consequences are actually quite profound in terms of trying to get us to where now we are trying to get to across the world, to the AIDS-free generation that we all dream of. It's one thing to know how to get there on paper. It's another to implement it in real practice. This is implementation research carried out in a resource-poor setting with a rigorous outcome being demonstrated. A few others I could mention, although not in as much detail. A randomized trial that you see the title of here, looking at weight loss and how self-monitoring may help using mHealth technology. Showing that it can play a role in improving weight loss, but perhaps not as strong a result as the original authors might have hoped for. Another one here looking at multiple behavior changes in diet and activity. Again, supporting the idea that remote coaching can be beneficial in terms of promise and improving diet and activity, but not as strong a conclusion perhaps as one might ultimately want to have about this kind of intervention, but assessed in a rigorous way. This one, which looks instead in a, which I can't actually read from where I'm standing, interventions to look at a particular place where they felt that the evidence was not strong enough to be able to draw a conclusion. And this in the British Medical Journal, looking actually at the opportunity to assess the effort to actually For individuals who've suffered cardiopulmonary arrest, does it help to have a connection to assist with those first responders in terms of how they're conducting the particular rescue effort? Not associated, however, with improvements in return of spontaneous circulation or other clinical outcomes. So not the result probably that the individuals had hoped for. Again, I show you these as in early examples, and many of them do seem to have reached conclusions that are a little less certain than one might hope. So why is that? Why is this so hard? I'll come to that in a moment. This is an interesting example where, in this case, there's now a review done by the Cochrane collaboration, where they looked at 5 different studies on mobile phone-based interventions for smoking cessation, obviously an application that we would all love to see be successful. And a very difficult circumstance, as you all know, because the ability to get individuals to stop smoking and to be able to maintain that has been one of the biggest challenges in terms of prevention health. They looked at 5 studies which collectively had 9,000 participants. And they looked to see what was the evidence in these studies, which were generally well controlled and mostly randomized. Could they in fact determine whether there was benefit? There's always a risk in pooling studies that have slightly different parameters, and they admitted that. But overall, they were able to show, when they put these together, that there was an improvement in the ability to quit smoking, as assessed by the fact that people were not smoking after 6 months after the intervention had been started, which is a fairly traditional way to assess success. Specifically, the relative risk of being a non-smoker, which is what you want, was 1.71. The 95% confidence limits on that were 1.47 to 1.99. I tell you those numbers because that's the kind of statistics that people looking at these studies would want to see, both what was the benefit and what's the confidence limit on that. And if they had not had 9,000 individuals, if they'd had 12, they would probably not be able to say what the confidence limits were, and it could be that that was just a coincidence that they got that 1.71 relative risk. So big numbers turn out to be really important in these kinds of studies if you want to get definitive answers. If you look, as Bob Kaplan, who graciously introduced me a few minutes ago, did, at the whole literature now in terms of what's been published about evaluations of mHealth using randomized controlled trials, they could only find in this review, which is online available and coming out early next year in print, only 20 of these between 2008 and 2012, which is a breathtakingly small number when you consider how much this technology is happening, and the fact that, as I started out, something like 1 out of 5 individuals with a smartphone has a health app on that phone. Of the 20 trials that were done, 55%, 11 of them, failed to document a clear benefit of the mHealth intervention, showing that it is often the case that these studies don't give you the result that you might have expected based on intuition for all kinds of reasons. 15% had a mix of some positive and some negative results. Only 6 of these 20 trials showed clear benefit, and I've mentioned a couple of them already. So we have a ways to go here in terms of being able to provide the scientific, rigorous foundation that this field very much needs and deserves. Problems with the current approaches to health research, and this would be true of all kinds of other areas of clinical research, but just to go through them. First of all, small numbers are a real problem. Power to demonstrate benefit is going to be greatly reduced unless you have large numbers of individuals, as I mentioned with that smoking cessation intervention. Another is the choice of subjects, which may in fact make the trial easier, but I'll make it very difficult to generalize the results. So ideally, if you're setting up a trial, you would like the participants to resemble the people who will eventually use this intervention in the real world, so that you can extrapolate and not have a major difference in outcomes. For this field, a big challenge is that the technology is changing so rapidly. And if you're going to mount a trial of efficacy that's going to take 4 years, by the time the trial is over, the technology will seem obsolete. So this puts a particular stress on the system here. Ideally, of course, one would hope to test technologies which, while the details may vary based upon advances which are happening every day, the fundamental approach is likely to be more durable, and so you can test the fundamental approach even without depending on a particular instantiation of that in a particular technical approach. That, of course, still means, though, that you want these efficacy studies, once they're mounted, to be carried off quickly so that you have the results in time to influence making about where to go. And that's actually not so easy. Oftentimes the way clinical trials are done takes a long time to do the design. You have to get human subjects approval in many instances, and then of course you need to enroll patients, follow them, get the results, do the data analysis, and so on. One of the things that some of us are working on is to try to see whether it might be possible in the US to develop a national research network that would include 20 or 30 million individuals whose care is currently delivered through healthcare organizations that have electronic health records and that have some familiarity with research. Imagine having that as a foundation where you could mount these kinds of studies very quickly and with low costs in terms of marginal costs, because the framework would have already have been provided by the network's existence. That is something which many of us are hoping we might be able to bring into reality in the next couple of years as a real opportunity to do clinical research in a new way in the real world. And of course, a very important aspect of clinical trials is that you don't just want to hear about the ones that gave a positive result. You also want to know about the failures. They're at least as informative. And yet the way publications work, oftentimes you only learn about those that gave a result that seem to indicate benefit. And this publication bias can actually give you quite misleading results. If you tested a particular technology in 10 studies and one of them was positive and 9 of them were negative, and you only saw the one that got published being positive, you would obviously be misled. ClinicalTrials.gov is an enterprise to try to collect information on clinical trials of therapeutics as well as diagnostics as well as mHealth. And this will be a way, and is increasingly a way, where all such trials get entered at the onset of the trial and the data ultimately appears there. So even if the results are negative, it's possible for individuals to find that out. And certainly that is, I think, strongly to be encouraged so that we learn as much as we can about this field. Anyway, the bottom line here is that I think mHealth technologies should be scientifically evaluated using the methods that have been shown over many decades to enhance effectiveness and safety of other interventions. And to skip over that step would be unfortunate. So that's mostly what I wish to say to you. But I think if you want to learn more about this whole perspective and to talk about ways that the various sectors involved between academia and industry, the National Institutes of Health, patient advocates, foundations, and many other components here, I would urge you to consider dropping by this afternoon to a session that you see listed here, the mHealth Public-Private Partnership, which Bob Kaplan and Wendy Nilsson have been leading. And that is supposed to start 6 minutes ago, although I suspect they'll wait for you. And I know from what I heard talking to Wendy, there are 180 people or something like that signed up. But you're welcome to come if you didn't sign up, because there is room. And this is going to be in room 13, if you're interested. And they will spend most of the afternoon talking about how to bring these various partners together in a way that will advance the field in special ways. The goals of this public-private partnership you can see here: creating an infrastructure, supporting education, promoting research results, and helping to generate, as I've tried to particularly emphasize here, a robust evidence and knowledge base of effective technologies by instilling a culture for continuous learning using appropriately rigorous scientific methods. Finish with a quote from Richard Feynman. And again, I hope I'm not sounding too much like the schoolmaster here, but it does seem that this technology, which has such promise, needs to be subjected to the same kind of skepticism and rigor as all other kinds of science. Feynman actually put this in his comment after he was asked to be part of the group that reviewed the Challenger disaster at NASA, and basically concluded that steps had been skipped and things that were assumed to work had never actually been tested at the level that they should have been. For a successful technology, he says, reality must take precedence over public relations, for nature cannot be fooled. Well, we don't want to fool nature. We want to benefit human health. All of you are gathered here at this remarkable meeting to make that happen. We are your partners. We would love to hear from individuals who have ideas about such research projects. Please do not be shy to bring your ideas forward this afternoon or at any other time to Bob Kaplan, to Wendy Nilsson, to myself, to Roderick Pettigrew, who's been here for much of the meeting, who's the director of our National Institute for Bioimaging and Bioengineering. We're enormously excited about this field, and we want to see it grow, blossom, and flourish. Thank you all very much.